Usually when we think about antibiotics, we picture something like a microscopic smart bomb.
Right, yeah, a very precise little weapon.
Exactly. Like
Yeah.
you get an infection, you take a pill, and the drug just naturally finds the target, and then it precisely neutralizes the threat.
It's a very comforting mental model, I mean, for all of us. We generally like to imagine modern medicine as this perfectly targeted, flawless intervention.
Right. It enters the body, does its job quietly, and just leaves. It
Yeah.
feels clean, it feels, engineered and incredibly safe.
Yeah, but that model doesn't always hold up.
No, it really doesn't. Because then you look at a specific class of drugs, and that whole smart bomb metaphor just completely falls apart.
It shatters, honestly.
Right. Suddenly, you aren't looking at precision warfare anymore. You're looking at, well, basically a medieval siege. It's aggressive, it's messy, and it is incredibly volatile.
Very volatile.
So, welcome to another deep dive. Today, we are taking you into the world of a pharmacology text we've got right in front of us. It's a document that breaks down this fascinating class of drugs called aminoglycosides.
It's quite a mouthful, but it's such an important group of medications.
Definitely. And our mission today is to uncover the secrets of these strong gram-negative killers. We're going to explore exactly how they work, the intense controversies behind their discovery.
Oh, the drama is real with this one.
So much drama. And we'll also get into the high-stakes, double-edged sword of their toxicity.
It really is a remarkable journey. I mean, we're talking about a family of drugs that includes names you might have actually seen on a hospital chart.
Like, what are some of the big ones?
Well, you've got streptomycin, gentamicin, tobramycin. They are incredibly powerful, but they demand, absolute respect from the doctors prescribing them.
Because the side effects can be severe, right?
Yeah, if used incorrectly, the collateral damage to the patient can literally be permanent.
Wow. And that's exactly why we're doing this deep dive. This is for you, the listener, who loves understanding the actual why behind medical decisions.
We're not just going to read you a textbook.
No way. We're going to take these dense textbook facts and turn them into some serious aha moments. So let's just start at the beginning, which happens to be a basement in New Jersey in 1943.
A very unglamorous setting for a medical miracle.
Right. What exactly was happening at Rutgers University back then?
So at the time, there was this microbiologist named Silman Waxman, and he had set up this massive research program in his soil microbiology lab.
Okay.
He was systematically screening soil actinomycetes, specifically this genus of bacteria called streptomyces.
Wait, so he was literally just sifting through dirt?
Literally. Thousands and thousands of dirt samples. He was looking for microorganisms that naturally produce chemicals to kill, other microorganisms.
But what was he actually digging for? Like, was this just broad scientific curiosity, or did he have a specific target in mind?
Oh, he had a very specific, very desperate target. He was looking for a cure for tuberculosis.
Ah, TB.
Yeah. You have to keep in mind the historical context here. Penicillin had been discovered back in 1928, right? And it was being mass-produced by the early 40s.
Right, the ultimate miracle drug.
Exactly. It was a miracle, but it had this glaring blind spot. Penicillin was famously inactive against Mycobacterium tuberculosis and most gram-negative rods.
It just couldn't touch them.
Right.
Yeah.
So Waxman wanted to find the missing puzzle piece. He wanted the drug that could do for gram-negative bacteria and TB what penicillin had just done for gram-positive infections.
And they actually found it. Streptomycin.
Yep. The very first antibiotic effective against TB.
And the very first member of the aminoglycoside class. But our source text outlines this massive scandal in the origin story. Waxman wasn't actually the one down in the dirt finding the cure, was he?
No, he absolutely wasn't. The person who did the actual hands-on bench work.
The actual science.
Yeah, the tedious isolation, the culturing of the organism in that dingy Rutgers agriculture building basement. That was a PhD student named Albert Schatz.
Okay, grad student, typical.
Yeah, Schatz was working under Waxman's direction, but he was the one physically running the experiments day and night.
Okay, I have to pause here because this is just infuriating. When it came time to hand out the credit, Waxman took it all, didn't he?
He really did.
He took sole credit, and then in 1952, Waxman was awarded the Nobel Prize in Physiology or Medicine entirely by himself.
Well, Schatz was totally sidelined.
Right, and Schatz actually sued Waxman in 1950, before the Nobel was even awarded. He sued for a share of the patent royalties and, formal recognition.
Which was incredibly bold for a grad student at the time.
Seriously. And the court legally recognized Schatz as a co-discoverer, but Waxman still took the Nobel alone. I mean, how could the scientific establishment of the time justify giving the ultimate tries to the boss while completely ignoring the guy who physically cultured the organism? I feel outraged on behalf of grad students everywhere.
I mean, it is arguably one of the clearest, most well-documented cases in 20th century science of a junior researcher's discovery being just completely absorbed into a senior scientist's credit.
It's so unfair. What was Waxman's excuse?
His defense was essentially that Schutz was just, quote, a pair of hands executing his broader intellectual vision.
Oh, that is so condescending.
Yeah, and Schatz spent much of his career effectively blacklisted from top-tier academic positions just because he dared to sue his mentor to fight for historical recognition.
That is just brutal.
It is a dark chapter, for sure. But, what's fascinating here is how this specific soil screening logic, despite the bitter personal controversy, it became the absolute blueprint for the next 2 decades of antibiotic discovery.
Because they realized the dirt beneath our feet is basically a constant microscopic battlefield.
Exactly. They realized the soil is full of bacteria constantly inventing chemical weapons to kill each other.
So they just kept digging in the dirt.
Literally. They followed that exact same logic against different species of soil bacteria, and that's how we eventually got neomycin in 1949.
Oh, wow.
Yeah, and kanamycin from Japanese soil samples in 1957, and gentamicin in 1963. They built this entire arsenal of weapons straight from the soil.
Okay, so we have this powerful new arsenal from the dirt. But to understand why these drugs became such a medical holy grail, we have to look at how they actually operate.
Right. The mechanism.
Because it isn't just about the fact that they kill bacteria, it's about the bizarre way they actually break inside. And the textbook definition of these drugs actually had to change over time, didn't it?
It did, yeah. In the early 20th century, scientists lumped aminoglycosides into this broad bucket called protein synthesis inhibitors.
Right, alongside other common drugs like tetracyclines.
Exactly. They defined the drug family purely by where it binds inside the bacteria. But as microbiologists looked closer, they realized aminoglycosides are a totally special case.
Because they shouldn't just be defined by their internal target. It's about the extreme difficulty of their entry.
Yes. They are incredibly stubborn molecules.
Right, because they can't just float through the bacterial membrane.
Mm.
The source text points out that aminoglycosides are highly polar, positively charged molecules.
Which is a huge structural barrier.
Yeah. For those listening who might not, love chemistry,
Yeah.
imagine trying to push two magnets together at their positive poles. They repel.
Right. They just push away.
Because of that structural charge, the drug hits the bacterial wall and just bounces off. It cannot passively slip inside. It actively needs to be dragged across the barrier.
And the mechanism doing the dragging is completely brilliant. The drug basically hijacks the bacterium's own oxygen-dependent electron transport chain.
The bacteria's own machinery.
Exactly. The bacterium actually uses its own metabolic energy, which specifically requires oxygen, to actively pull the drug across the membrane and into its own cell.
I love this concept.
Yeah.
Think of oxygen like a VIP pass at an exclusive club.
Oh, that's a great way to look at it.
Right. The bacterial membrane is the bouncer, and the ribosome inside is the dance floor. If you don't have that oxygen VIP pass, the bouncer is absolutely not letting the drug in, no matter how badly it wants to hit the dance floor.
That is a perfect way to visualize it. And the biological reality of that VIP pass dictates incredibly strict clinical rules today.
Because if there's no oxygen, it just doesn't work.
Exactly. Because cellular uptake absolutely requires oxygen. Anaerobic bacteria, which live entirely without oxygen and lack that specific transport chain, are intrinsically resistant.
The bouncer just says no.
Every single time. The drug is completely useless against them. This is why doctors never prescribe aminoglycosides alone for, abdominal or pelvic infections.
Because those areas are where oxygen-hating anaerobic bacteria thrive.
Right. It also explains why these drugs fail miserably in an abscess. If a patient has a walled-off abscess, that is a highly acidic, very low oxygen environment.
Which completely busts this lingering misconception that aminoglycosides are these magical, quote-unquote, broad-spectrum drugs that just work on everything, everywhere. Yeah, that's a dangerous myth.
If there's no oxygen, they're locked out. So if a doctor is facing an abscess, what do they actually do?
Well, in real-world clinical practice, a doctor knows they have to physically drain an abscess with a scalpel or a needle.
They can't just rely on the medication.
No, they cannot just throw an IV aminoglycoside at the patient and expect the drug to sterilize that pocket of infection. The drug simply cannot get inside the bacteria in that specific environment.
Okay, so they're totally useless without oxygen. But what happens if a patient has an infection where the bacteria does use oxygen, but the cell wall is just naturally too thick for the drug to get through?
Oh, yes.
Like, is there a way to force the door open?
Now you're getting into the concept of synergy.
Hmm.
And the classic medical example of this is the treatment of enterococcal endocarditis.
That's an infection of the heart valves, right?
Very dangerous.
Incredibly dangerous.
Yeah.
Enterococci are naturally resistant to aminoglycosides because their outer cell walls are just too thick and robust to penetrate. The drug just bounces off.
Okay, let's unpack this. If we use a castle metaphor, the cell wall is the reinforced castle door. The enterococci are safe inside.
Right, tucked away.
If you just send the aminoglycoside troops by themselves, they get stuck outside the door and do absolutely nothing. But in the 1970s, researchers discovered a brilliant workaround, didn't they?
They did. They paired the aminoglycoside with a completely different drug, a cell wall active agent like penicillin.
And that combination changed everything. Because the penicillin acts as a battering ram.
Yes.
It smashes physical holes in the structural integrity of the castle door.
That battering ram effect is precisely what happens. The penicillin perforates the armor, which allows a massive amount of the aminoglycoside to flood in and hit the internal target.
So once the door is perforated, the aminoglycoside troops can absolutely flood the courtyard and take the castle.
Exactly. And they completely clear the infection. If you only use the penicillin, it would just suppress the bacteria without fully killing it, but together they cure it. And this wasn't just some neat laboratory trick. It became the absolute cornerstone of infective endocarditis treatment guidelines. It is considered a masterclass in rational combination therapy.
So our troops have flooded the courtyard. The drug is finally inside the bacteria. But how exactly does it execute the target so quickly?
It's pretty aggressive.
Because the text makes a massive point that these drugs are bactericidal, meaning they are active killers. Unlike other antibiotics that are just bacteriostatic, which basically just stall or pause the bacteria's growth, what is the actual weapon here?
It comes down to a really devious, multi-step kill mechanism. Inside the cell, the aminoglycoside targets the bacteria's protein factory, the ribosome.
Okay.
Specifically, it jams itself into the machine's decoding site. Think of it as sabotaging the exact spot where the bacteria reads its own genetic instruction manual.
So it basically scrambles the instructions.
Completely. It distorts the decoding site, which forces the bacteria to accept the wrong building block. Yeah, so the bacteria starts misreading its own genetic code, and it furiously pumps out these error-riddled garbage proteins.
But just manufacturing bad proteins isn't what makes it kill so fast, is it? It's what those bad proteins do next.
That's the fatal loop.
Yeah.
Some of those misfolded garbage proteins get accidentally inserted into the bacterial membrane itself.
The wall of the bacteria.
Right. And because they are structurally flawed, they literally punch holes in the membrane from the inside out.
So the drug gets in, tricks the bacteria into building faulty walls, and then the faulty walls let even more drug flood in.
It's a self-amplifying uptake loop. That massive, rapid influx is exactly why they are so lethal.
That is terrifyingly efficient.
It really is. And this specific mechanism is why aminoglycosides are classified as concentration-dependent killers.
Meaning they need a high concentration to work best.
Yes. For some antibiotics, like penicillin, efficacy depends on how long the drug stays above a certain threshold in the blood. That's called time-dependent killing.
Okay, so slow and steady for penicillin.
Right. But aminoglycosides kill faster and more completely based on how high the peak concentration gets. You want a massive spike. They also have what's called a post-antibiotic effect.
Meaning they keep suppressing bacterial growth even after the drug levels in the bloodstream have technically dropped back down to zero.
Exactly. And understanding that fatal loop and the need for a massive peak concentration led to a huge paradigm shift in the 1990s.
This is driven by people like Charles Nicolau, right?
Yes, driven by extensive pharmacokinetic research by Nicolau and others who looked at how the drug actually moves through the human body.
And this was the shift in how hospitals actually dosed the drug. They moved from giving patients 2 or 3 smaller doses gently spread throughout the day to giving one giant, massive daily infusion.
That became the new standard.
But hold on, I have to push back here. We know these drugs are toxic. If this stuff is dangerous, wouldn't giving a patient one massive, highly concentrated dose be more dangerous than spreading it out gently?
I know it sounds completely counterintuitive, but the single large dose is actually less toxic.
Really? How does that work?
To understand why, we have to look at how the kidneys process the drug. When you give divided, smaller doses every 8 hours, The drug levels in the blood never fully drop to zero.
Okay, so the kidneys are just always dealing with it.
Exactly. The kidneys are constantly bathed in the drug, and it slowly accumulates in the kidney tissue until it causes real damage.
So constant low-level exposure is actually worse.
Much worse. By giving one massive dose, you achieve two things. First, you get an incredibly high peak in the blood, which maximizes that concentration-dependent killing of the bacteria.
You hit the bacteria with a sledgehammer.
Right. But second, because you give it all at once, you allow the drug level to fall almost completely to zero for a long stretch before the next day's dose.
So you give the kidneys a rest.
Yeah.
They literally have time to completely clear the drug out of their system before the next wave hits.
Precisely. You maximize the bacterial death while minimizing the accumulation in the human organs.
So we're flooding the patient's system with a massive concentrated dose just to spare the kidneys. But why are the kidneys so vulnerable in the first place?
That's a great question.
Because that brings us to the dark side of how this drug travels through the body. This is the exact reason doctors have to be so incredibly careful, because the toxicity is severe, and it's basically a double-edged sword.
Yeah, the toxicity isn't just an allergy or a random side effect. It is mechanistically linked to the drug's fundamental properties.
Right.
After the drug circulates in the blood, it naturally accumulates heavily in two very specific places: the kidneys and the inner ear.
Okay, so in the kidneys, the drug is taken up by these specialized filtering cells. And our source text mentions these cells have a specific receptor on their surface, the megalin receptor, that acts almost like a magnet for this drug.
It just pulls it right in.
It pulls the drug inside, it builds up, and it damages the cells, causing nephrotoxicity. But in the ear, it accumulates in the delicate hair cells responsible for hearing and balance, causing ototoxicity.
But there is a crucial life-altering difference between the two types of damage.
Which is?
Kidney damage from these drugs is usually reversible. If a doctor notices the kidney marker is slipping, they start the drug, and those filtering cells can actually regenerate over time.
Okay, that's somewhat comforting.
But ear damage, however, is frequently permanent. Human cochlear hair cells do not regenerate. Once they die, the hearing is gone forever.
Here's where it gets really interesting. Think about it like a car.
Okay.
The kidney toxicity is like scratching the bumper. It looks bad, it's not ideal, but you can take it to the shop and buff it out.
Right, it's fixable.
But the ear toxicity is like throwing a rod in the engine. It is permanently broken. That asymmetry is exactly why doctors constantly monitor blood levels, trying to catch trouble before it crosses from reversible to permanent.
They're walking a tightrope.
But you can't always predict it with blood tests, can you? Because there is a terrifying genetic trapdoor here.
This is perhaps the starkest cautionary tale in modern pharmacology. There is a specific genetic variant in our mitochondrial DNA known as M.1555AG.
What does that actually mean for the person carrying it, like on a practical level?
Well, to understand it, we have to look at evolutionary history for a second. Billions of years ago, our cellular power plants, the mitochondria, were actually free-living bacteria that were absorbed by our ancient ancestors.
Wait, our cellular power plants used to be ancient bacteria.
Yes. And because of that, mitochondria still have their own separate DNA today, completely distinct from the rest of our cells.
That is wild.
It is. And in people who carry the specific variant, their mitochondrial ribosomes are structurally altered. They end up looking incredibly similar to the bacterial ribosomes that the aminoglycosides are designed to attack.
Oh, no. So the drug enters the patient's inner ear, looks at the patient's own mitochondria, and basically mistakes them for an invading bacteria.
Exactly. It attacks the patient's own cells. In carriers of this mutation, a single standard therapeutic dose of gentamicin, no prior exposure, no massive overdose, just a normal dose, can cause immediate, profound, and permanent deafness.
One single dose. That is devastating.
It's a tragedy.
And because mitochondrial DNA is passed exclusively from the mother, you see entire family clusters of this tragedy, generations carrying the mutation without knowing it until someone gets an infection.
It stays hidden until they get that one dose.
We've actually seen this tragedy play out historically in pregnancy, too. The text notes that in the mid-20th century, treating pregnant women for TB with streptomycin caused the drug to cross the placenta.
Right, with terrible consequences.
It damaged the developing fetal inner ear, causing infants to be born completely deaf, often while the mother had absolutely no symptoms at all. which is exactly why they fiercely avoid this drug class in pregnancy today, unless it's an absolute life-or-death situation.
And this raises an important question, one that is actively debated in hospital administrations today. Should we be mandating rapid genetic screening for this variant before administering these drugs?
I mean, it seems like a no-brainer if it causes permanent deafness.
It's one of the clearest examples in medicine of a single genetic variant turning a perfectly correct guideline concordant dose into an irreversible disability.
So why don't they test everybody?
The debate remains unresolved largely because rapid point-of-care genetic testing just isn't standard in the emergency rooms or ICUs, where these drugs are usually given urgently to save a life. You just don't have the time to wait for a genetics panel when a patient is in septic shock.
Which brings us to the modern era. We have a drug discovered in 1943. It requires oxygen, it punches holes in bacterial membranes, it forces us to use massive daily doses to spare the kidneys, and it carries the risk of permanent deafness if you have the wrong mitochondrial DNA.
It's a lot of baggage.
Why on earth are we still using an 80-year-old drug class with such terrifying side effects?
Because the bacteria keep fighting back, and we desperately need heady weapons, bacteria are constantly developing resistance to aminoglycosides.
How do they do that?
They primarily do this by deploying defensive enzymes that basically slap a biochemical cap on the drug molecule. They change the drug's shape just enough so it can't dock into the ribosome anymore.
So if they just keep putting biochemical caps on our drugs, how are doctors treating these resistant infections today? Like, are we just out of luck?
Not yet. To counter those bacterial defenses, pharmaceutical scientists have had to continuously engineer new, modified versions of the drug.
Okay, so we tweak the structure.
Right. That's why amikacin was developed in the 70s, and it's why the newest agent, plasmamycin, was approved in 2018. They are structurally engineered with synthetic side chains designed specifically to dodge those bacterial enzymes.
So we save them for the toughest cases. The text highlights that they're used as frontline therapy for serious gram-negative sepsis, complicated urinary tract infections, and multi-drug-resistant tuberculosis.
We also see some incredibly clever localized uses.
Oh, right, like inhaled tobramycin for patients with cystic fibrosis.
Exactly.
Since it's inhaled directly into the lungs, you get a massive concentration exactly where the chronic infection is.
Exactly.
But you limit the drug from absorbing into the bloodstream, which neatly avoids that kidney and ear toxicity we just talked about.
That's a brilliant application. You leverage the extreme killing power while physically restricting the drug from reaching vulnerable organs.
But wait, a quick misconception to clear up for you listening. You cannot just take an aminoglycoside pill for a bad systemic infection, right? Like, if you have a blood infection, your doctor isn't writing you a script for pills.
Correct. Remember how polar in charge these molecules are?
The magnets.
Right, the magnets. They are so poorly absorbed from the gut that an oral pill, like neomycin, just stays entirely inside the intestinal tract. It never enters the bloodstream in meaningful amounts.
Which is actually useful if you specifically want to sterilize the bowel before an intestinal surgery. Or, treat a liver condition where you need to kill off ammonia-producing bacteria in the gut.
It's great for that.
But it won't help an infection anywhere else in the body. If you want it in the blood, it has to be an IV or an injection. But I have to ask, if we keep having to invent new versions like plasmamycin just to outsmart bacterial enzymes, aren't we eventually going to lose this arms race?
Well, if we connect this to the bigger picture, the reality is that the pipeline for totally novel antibiotic classes has slowed to a terrifying trickle.
We just aren't finding new ones.
We aren't discovering entirely new ways to kill bacteria very often anymore. Because of that, older, heavily engineered drugs like aminoglycosides are increasingly becoming our crucial drugs of last resort.
So we just have to accept the risks.
We tolerate the extreme risks, the ototoxicity, the nephrotoxicity, because for many pan-resistant gram-negative superbugs, the older, cheaper, and safer antibiotics simply do not work anymore. We are out of gentle options.
So what does this all mean? We started this deep dive talking about the journey of aminoglycosides. From a fiercely contested discovery in a New Jersey basement, driven by a grad student sifting through dirt, to becoming a highly engineered weapon of last resort.
It's been quite a ride.
We unpacked that brilliant, self-amplifying, hole-punching mechanism, the clever, once-daily dosing paradox to protect the kidneys, and the devastating genetic trapdoors lurking in our own evolutionary DNA.
It is a drug class that demands absolute precision and respect from the medical community.
It really does. So the next time you hear about antibiotic resistance or precision medicine, you now know exactly how high the stakes really are, down to the oxygen the bacteria breathes and the ancestral DNA inside your own cells. It is not a smart bomb. It is a medieval siege weapon, and sometimes when our backs are against the wall, that is exactly what we need to survive.
And it leaves you with something fascinating to consider. If an 80-year-old chemical weapon naturally produced by soil bacteria is still our absolute best defense against some of the most dangerous superbugs in hospitals today, it makes you wonder what other ancient microscopic warfare tactics are playing out in the dirt beneath our feet, just waiting for the next Albert Schutz to discover them.